what we want to do now, we want to start our consideration on the management of the third stage of labor. And the third stage of labor, this is the stage which begins from the time the baby is delivered up until the delivery of the placenta and all the placental membranes from the mother's uterus. Now, when we are considering the management of our third stage of labor, basically we use two methods of managing this. According to hospital policy, there is passive management of the third stage of labor, and that involves observing for signs of placental separation, such as gush of blood, um, appearance of the placenta on the vulva area, lengthening of the cord, the woman's age to push or to bear down. Those are some of the clinical signs that we should observe for when we are doing our passive management of the placenta and its membranes. Regardless of that, rather, our main emphasis for this talk is on the active management of the third stage of labor. Now, under active management of the third stage of labor, there are various rules that we are supposed to follow, and there are various techniques and procedures that we need to follow when we are doing this. So, the purpose of this talk, as mentioned earlier, is on the active management of the third stage of labor, and basically the principles and the steps that we follow when we are managing the woman in their third stage of labor. So we start with our management. As always, we are going to start with our aims. So what will be our aims when we are managing the woman in the third stage of labor? Our aims really should be our goal that we are supposed to attain at the end of this management. So for example, number one of our aims will be to prevent infection. We want to prevent shock. We want to prevent bleeding. We want to prevent the retained placenta and its membranes. We don't want the placenta to be retained, in other words. Those are some of the aims that we should look out for when we are dealing with a woman who is in the third stage of labor. Once we are done with our aims, environment. We write environment. Now, under environment, there is so much really to talk about, but for the purposes of keeping this video short, we'll just look at some of the things that we will need to look out for when we are dealing with the woman in the third stage of labor. So, we need to keep the environment clean. The labor ward is supposed to be clean, and it's supposed to be light, really. There is supposed to be good light. The labor ward is supposed to be free from noise. We don't want any noise. We don't want the woman to be disturbed. Always remember to keep privacy. So maintain privacy whenever you are doing each and every procedure in a clinical area, as always. Good ventilation is one of them. Now, what we want in this environment, of course, there are medical facilities or equipment that we will need in order for us to take care of the woman in the third stage of labor. What are those things? Oxytocin is one of them. So you need to have a 10 international unit dose for oxytocin already prepared on the delivery trolley. You need to have your sphygmomanometer to measure her BP. and a pulse. You also need to have a pair of gloves, sterile gloves, because this is an aseptic technique that is going to be carried on this woman. You need to have two spongy forceps for clamping the umbilical cord, and a pair of scissors that is going to be used to cut the cord. You need to have the resuscitation tray. You also need to have vitamin K for the baby. All such things are supposed to be needed. If not oxytocin needed, there is a drug that we use also that will initiate contractions in the labor ward, and that is misoprostol. That can be given 600 milligrams. And this drug really is very good for community birth attendant because it makes it easy for them to store and to carry it wherever they are going. Because as mentioned earlier on, oxytocin is going to be given either intramuscularly or intravenously if the woman has already an IV inserted on herself. So to mention but a few, those are some of the equipment and some of the materials that we are going to need when we are dealing with a woman in the third stage of labor management. Position. As always, the woman in labor is going to be positioned in a dorsal position. So you are going to position this woman in the third stage of labor in the dorsal position, and that will allow you to look out for any abnormalities of the uterus when it's contracting. You also have the right. You also have. You are also are going to manage to observe the woman eye to eye. That is eye contact, and also you are going to have the view of the vulva area, and that is under position. Once you are done with this, organizing these points, the next thing that we do is immediate management. So we go on our immediate management. And our immediate management, as it suggests, it's a management that will carry right there and then after, before several hours. So what is it that we do in our immediate management? Well, of course, we remember that we are dealing with two lives, the life of the mother and the life of the baby. So what we do is on our immediate management, the baby. What do we do to the baby? Since we are in the third stage of labor, the baby has just been born, the third stage of labor has begun. We wipe the baby to prevent hypothermia. Immediately the baby is born, we clear out the nose if there are any secretions, the mouth, we clear the eyes of the baby from inside outwards to prevent the spread of infection. In case the baby encounters any infection as it was sweeping the mother's perineal area. So very, very important to note that. We also measure we also assess the baby's APGAR score. An APGAR score is simply an acronym, and this is the one that is best used to determine or to measure the baby's asphyxia. Because what APGAR score really is, A stands for appearance, P stands for pulse, G stands for grimace, activity, and respiration. And these are going to be recorded in a single box. So for example, if the baby's score is 8 and above, because they are supposed to end up at 10, the APGAR score. The sum of all these is 10. So if the APGAR score is 10 and above, then that simply means that the baby is okay, the baby is doing okay. Now, if the baby score, APGAR score is 5 to 7, then that simply means there is some mouth asphyxia. And that simply means that the APGAR score is supposed to be returned at 10 minutes. Now, if the APGAR score is 4 and below, then that simply means there is severe asphyxia. And resuscitations will have to be made there and after, no delay in that. So very, very important that we assess the APGAR score on the baby as it is being born. And immediately put the baby on the mother's abdomen, abdomen to initiate bonding. And also you can put the baby on the mother's breast just in 30 minutes after delivery, in not more than 30 minutes, so that you initiate breastfeeding, because breastfeeding is going to cause contraction of the uterus. It is breastfeeding that stimulates the posterior pituitary gland to produce an hormone called oxytocin. And oxytocin will cause uterine contractions. So very, very important that breastfeeding is initiated within the first few hours of birth. Those are some of the things that we need to do on the baby. And the other thing that you need to do, don't forget to show the baby to the mother. So what you do when the baby is born, you carry out the baby and show it to them. Ask them, what child is this? Is this child a male or a female? And you should allow them to say it. Once they are done, then put an identification band on the baby, indicating the name of the mother, the date, time of delivery. All those things are supposed to be put on the baby once it's born. Once you are done, you go to the mother. So that is our immediate management. We are from the baby, now we move on to the mother. What are some of the things that we do on the mother immediately the baby is born? Immediately we are in the third stage of labor. The first one, oxytocin. Administration of oxytocin. This is the first step in the active management, in the immediate management of the mother. So administration of oxytocin. How do we do this? Well, immediately the baby is born, the first thing that you're going to do is palpate the mother's abdomen to rule out the presence of another fetus, in case there is another fetus or a second twin. So you palpate the mother's abdomen nicely so that you rule out the presence of another fetus. If you are sure that there is no second twin, then administer oxytocin intramuscularly. But before you do that, tell the mother, explain to her that we are going to administer this drug, and what this drug is going to do, it's going to initiate contraction of the uterus so that we expel the placenta and its membranes and any blood clots. We prevent bleeding. Tell her, the mother, so that she's aware of whatever procedure you are doing on her. Once you do that, you administer oxytocin on the mother's thigh muscle intramuscularly. But if the mother has already an IV inserted on her, then you can administer it intravenously. And the unit for oxytocin is 10 international units. You have it already prepared on your delivery tray, right? 10 international units of oxytocin. Clamping and cutting of the cord. Now, after you administer oxytocin, you wait for contractions. There is no hurry in cutting the cord. Really, it suggests that a delay of at least 1 minute when cutting the cord is advisable, because all the nutrients that were retained in the mother's placenta will have already gone to the placenta. But if you wait for at least 1 minute, all those nutrients will come from the placenta and go to the baby. That's when you can cut. And this is good because it's going to prevent the child from developing anemia, and all antibodies that were in the mother's placenta are going to go to the baby before you cut the cord. And how you do that, you can wait for the placenta, the cord to stop pulsating, because it's pulsates so much. So when you see that it has stopped pulsating, then you can also cut the umbilical cord. So how you cut this, you get the two spongy forceps. So here is the cord, here's the umbilical cord. You get the two spongy forceps, you put one here from the mother's perineal area and the other one here at an area of around about 3 centimeters. So at this point here, they're supposed to be at least 2 to 3 centimeters apart. That's when you can get your blunt scissors and cut. Once you're done with that, then the second thing, the third thing that you're going to do is now, still under immediate management on the mother, on the steps to, so we are from cutting, clamping and cutting of the cord. The next thing that we do now is controlled cord traction. We have already cut the cord, so we need to start the controlled cord traction. Now, how do we do this? So you get your left hand, your left dominant hand, you press it on the mother's pubic bone, just above the mother's pubic bone, and you get another one, you hold the cord down there where the spongy forceps is, and then you don't start pulling on the cord yet. You wait for the mother's uterus to contract a little bit. Once you see that the uterus has contracted, normally it feels round like a ball or a tennis. Once you notice that, then you can start holding the uterus back while you are controlling, you are pulling on the cord. That is what we call controlled cord traction. And pull it downward gently. Do not pull hard on the cord, because that can promote uterus invasion. So pull it gently, and while you pull it, once you see the placenta on the vulva area, then that's when you can hold it nicely, turn it until the membranes, to prevent the membranes from not separating inside. When you turn it, you are going to allow the membranes to separate nicely from the uterus, so that you can remove it without any complications. Now, once you're done with that, then the next thing that you're going to do, so you, after controlled cord traction, that is controlled cord traction, you can put on your management list delivery of the placenta. And this is okay, because I think this has been just talked about, because this is where when we see the placenta coming from the vulva area, you hold it with your two hands, and the receiver downward there, you twist it so that the membranes can separate nicely, gently, and put it on your receiver. After that, you do your observations. So you do your observations. But before you do your observations, you need to massage the uterus. So we are going to put uterine massage. This is how we organize our points, even when we are in our exam room. And this is exactly how the the procedures are taken when we are managing the woman in the third stage of labor. So throat contraction, delivery of the placenta, uterine massage. You massage the mother's abdomen, and this will help for the contraction of the uterus also. And if there are any clots remaining in the uterus, then they are going to come out probably. This is best because it's also going to prevent bleeding. So you say all those things when you are doing this. When you're done, that's when you can put on observations. So that will be on your subsequent management rather if you want, but I'll just continue in light observations. What do we do on our observations? Well, we do our vitals. We do our pulse rate, respirations, BP, blood pressure. We measure that. And we observe our placenta because you can also put examination of the placenta or assessment of the placenta. We have a talk, or rather a full lecture, on the examination of the placenta. Because if we talk about this in this lecture, it will be too bulky and it will be hard to remember. So what we have just done is we have got a lecture in which we have talked about the full examination of the placenta. But in this case, for the purpose of remembering, we are going to talk a few about the examination of the placenta and what we do on the placenta once the baby is born. Once the placenta has been just delivered. We turn it around and press it facing the mother. The maternal side will be down and the fetus side will be upward. So what we do is we start by examining the membranes if they are present. We examine the size, the shape, the color, and the smell. Once we are done, we examine the cord also. At the point where you had cut the cord, you assess how many vessels are there. Usually they're supposed to be 3 blood vessels. There are 2 arteries in 1 vein. Those are umbilical vessels. So we need to have 3 vessels. Once you're done, you turn the placenta around also. You observe for the lobes, or in other words, the cotyledons. And there are about 15 to 20 of these. So you observe, that is on the maternal side once you have turned it around. You observe if there are any clots or any area which is infected. Infarction. So you observe all those things on the maternal side, and once you are done, you can thank the woman and praise her, saying, "Well done job," and that is all about. In the next talk, we are going to start talking about puerperium, and that is the period from the birth or from the delivery of the placenta and after 6 weeks.